So, good afternoon, everybody, and welcome on behalf of Efcca to another Patient Talks. We are delighted to welcome you all again. Today, we're looking at a really interesting topic for many patients. So, we're going to be joined by three medical teams from Portugal in relation to a Family First survey, which is the global survey on the first-degree relatives of IBD patients on preferences and fears for prediction and prevention and intervention in relation to first-degree relatives of IBD patients. So we are delighted today to be joined by Professor Joanna Torres, Dr. Catarina Fidalgo, and Barbara Moran, who all join us from the Hospital Beatrice in Portugal. So as usual, please, if you have any questions, please put them into comments and we can ask them after the presentation. So I'd love to welcome Dr. Fidalgo onto the screen, and I'll leave it to her to do the presentation.
Hello, everyone. I hope you can hear me. So I'm a gastroenterologist working in Portugal. I've had the great honor of participating with Efcca, and I think the alliance between physicians, researchers, and patients is the way to go in research for IBD. So I'm really glad we can join forces to shed some light on this project. And I would like to start my presentation, and in the end, hopefully you have questions for us and you can join our project, which is aiming at first-degree relatives of IBD patients. So I will ask Antonella to put on the slides so I can start the presentations. So this is about family, this is about first-degree relatives, and what we want is to know the preferences and fears of relatives of IBD patients, about mechanisms for early diagnosis and prevention strategies in relatives at risk. So as you all know, the prevalence of IBD is on the rise. So we need to improve treatment, and hopefully we can know the cure for this disease. But in the meanwhile, we have to improve our prediction tools and prevention strategies to try and prevent people at risk from getting the disease. So I will try to break down this image from Professor Torres for you, basically to say that we know there is a preclinical phase to IBD. Many years before the patient has symptoms or has the first crisis, the disease is already there. We know that there are genetic predispositions for the disease that can be affected by environmental factors such as smoking or diet, but then the disease starts, and for many years it can be under the radar, sort of, meaning that the patient is not aware that it has this predisposition or this disease. And this would be the window of opportunity to make some interventions that prevent the individual to even develop the disease. So first, we need to identify these individuals at greater risk, and then hopefully we can offer them preventive measures to try to delay or even prevent the disease to start. This is an ambitious idea, but actually is already being done in other diseases. Here we have the example of type 1 diabetes, and we can see above that researchers developed a prediction model. They take into account some blood tests like antibodies, genetic factors, and family history, and they can accurately predict which individuals will develop type 1 diabetes. And then after selecting them, they offer them an intervention. In this case, it's once only treatment with a biologic called teplizumab. And as you can see in the graphic below, this intervention seems to delay the beginning of type 1 diabetes by 24 months in individuals at risk. So this is the type of design of intervention that is being done in other diseases. So here we are not targeting IBD patients. We are actually targeting people at risk of having IBD. And we have some clues about which individuals are at greater risk. For example, we know that exposure to heavy metals such as lead in the childhood can increase the risk. But actually, of all the clues we have so far, we know that the people at higher risk of having IBD are actually first-degree relatives. So this is the ideal population to start a project about prediction and prevention. So hopefully we can get a prediction model that will take into account the results of blood tests, stool tests, endoscopy, or imaging tests, and select the population at higher risk. We intend to perform a series of focus groups. This is the first step of our project with first-degree relatives, for example, siblings or children of IBD patients, to assess the preferences and fears towards these prediction and prevention strategies. What types of scenarios will we discuss in the interviews? For example, we want to know how willing would an individual be to get a colonoscopy as a prediction tool, or how acceptable would it be for him to start a biologic when he doesn't have the diagnosis of IBD yet. For example, if a model could tell you accurately your odds of getting IBD in your future, would you rather not know it, or would you want to live with that information? And would you agree to start your child at risk for IBD on an intervention such as, for example, a special diet for preventive reasons? This is the kind of scenarios we want to explore in the focus groups. Of course, we can imagine the scenarios, but what is expected is that you give us clues that we did not anticipate. This is the goal of the focus group, is not to tell us what we already know, is to surprise us with fears, preferences, and questions that we did not anticipate as researchers. So this will not be guided interviews, but rather we are hoping for new clues and new variables to take into account. So as you can see in those balloons above, there can be lots of things going through your minds right now. And that's the goal of the first step of the project, is to know what's in your mind and your heart about this. Why does this matter? Because we feel that before designing research, individuals' views must be taken into account. Of course, we could proceed directly to these interventions, but we feel that the right way to do it is to involve individuals beforehand and know what they feel about this. In fact, this is quite important because other researchers in other diseases have found out that this is quite relevant. For example, in rheumatoid arthritis, the first-degree relatives talked about anxiety associated with the uncertainty of the predictive tests. They felt they needed support to deal with so much information. They had lots of concerns about safety and side effects and efficacy. And they told researchers that their willingness to try something would be very dependent on the ability of the prediction tool to tell them what is the real risk of having the disease in the future, because we could be willing to accept certain interventions if we perceive the risk to be high, but we may not be willing to accept those interventions if we perceive the risk to be low. So this is very important. How will we do it? We will run the recruitment through Efcca starting today. So wait for the link on the last slide, because you can already be recruited to participate in the focus groups. We have inclusion and exclusion criteria. Of course, there will be an informed consent, and all data will be pseudo-anonymized, so there's data protection guaranteed. We will ask you to fill out a baseline questionnaire online, and then we will conduct the focus groups, meaning it's semi-structured interviews with a maximum of 6 participants for a maximum of 2 hours. And hopefully we will reach a saturation point where no new ideas, fears, or doubts are raised. So this is about family. So I'm trying to pay homage to the Peaky Blinders. And I would like to say that we are searching for adult individuals, meaning they have to be 18 years old or older. They have to be able to give informed consent, of course. They need to be fluent in English language and must not be employed or be beneficiary of a pharma company or a device company for obvious reasons. We will want to have 2 groups of people. The first group is actually first-degree relatives of IBD patients, meaning a brother or a sister, a daughter or a son who is adult and is related in first degree to an IBD patient. But we also would like to explore the views of parents of children at risk for IBD. For example, a mother or a father of a child who does not have IBD but is at risk, either because one of the parents has IBD or because a sibling of that child has IBD. And here we want to explore the feelings of the parents about embarking on a preventive strategy or a prediction tool. The timeline will be recruitment will start today. Hopefully, we can conduct the focus groups in September. In October, perform the data analysis, and then write and publish the manuscript. But the final output of this project will be actually to launch a global survey. Next slide, please. A global survey aimed at first-degree relatives on this issue. And the output of this big survey would inform future research. So myself, Catarina Fidalgo, Bárbara Mourão, and Professor Joana Torres, who is the author of this project, together with the Portuguese Association for IBD Patients, with Ana Sampaio and Cândida Cruz, together with Efcca, would like to invite you to participate, and you can use this link on this last slide to volunteer to participate in the focus groups. You already have the available dates in September to join us. And I would like to thank you so much for your attention and hope we have many, many participants so we can move this forward. And I will be happy to take your questions or clarify anything if you like.
Thank you, Dr. Fidalgo. It's such an interesting topic, I suppose, as a patient with Crohn's and my father has Crohn's. It's really very interesting. If this had come out maybe 20 years, 30 years earlier, I may have known what was ahead of me. So we have loads of questions. I don't know whether Professor Torres is available to come on as well, and Dr. Moran as well. Just hello.
Hi, everyone.
So what I normally do, if this is okay with you, I'll ask the question and then whoever wishes to answer it, I have a good few questions. I suppose one question that came up, and it's something that I probably had to get my head around, is the definition of a first-degree relative. Is the parent or children of the patient? Am I right in thinking that?
So first-degree relatives would be brothers and sisters
of the patient.
Of the patient, the mother and the father of the patient, and the daughters and the sons of the patient. But actually, the mothers and fathers of the patient are typically in a time of their life where the diagnosis of IBD is not so frequent. So even though they are at risk, and we have a percentage of people who are diagnosed with IBD later in life, fathers and mothers would not be so much the scope of our project, because we feel that preventive interventions may have a window of opportunity to be made early in life. So even though they are first-degree relatives, their own right, we were more aiming on brothers, sisters, daughters, and sons. Of course, in the second group, the strategy is a bit different. It's about parents and their fears and their doubts about strategies on their children. So now we are looking for fathers and mothers of children at risk for IBD, either because their parents have IBD themselves, or because they have another child with IBD.
Okay, perfect. We have loads of questions, and I know there's loads of people watching, so I should say that we will share the link on our website and on Facebook afterwards as well. What do any of you know, or maybe you can give a ballpark, what is the most updated value of the prevalence in IBD?
So, Chiara, maybe I can answer that. So we know that the incidence of IBD, so the new cases of IBD, seems to be stabilizing in Northern Europe and North America, which are like high incidence countries, right? So, but every time a new case is diagnosed, the prevalence, which is the total cases, will keep increasing, because there will be every year there will be new cases, kind of summing up to the prevalence. So it depends. The incidence and prevalence depends a lot on the country where you are from. But it seems like that South Europe and Central Europe are kind of catching up with the countries like Denmark or Norway, Sweden, which were like the high incidence countries. So it kind of depends a little on each country, but roughly speaking, there is maybe in high incidence areas, there may be up to one patient per 100 individuals in very high incidence areas. So,
okay. And part of your presentation, you mentioned about that possibly one of the preventative measures might be diet. Is there still a theory, or is there a theory behind that diet can prevent a flare, can aid your life with IBD?
So we know that a diet intervention has value in treating IBD. We already know that, for example, in children, where we can induce remission with a diet intervention. And we also know that it can take a part in treatment. So it can be hypothesized that a dietary intervention can have a role in prevention as well. But that's one of the things we need to study. That's one of the avenues that is available for us for study. So we know that some diets have anti-inflammatory profiles, but we also know that diet influences the microbiome. So we are sort of, we can hypothesize to be doing both things with a dietary intervention, but that's one avenue that I expect that can be followed, particularly in children, perhaps.
So maybe I may just add that at Mount Sinai, there is one ongoing study with offering pregnant women with IBD a dietary intervention. Because they have shown before that those babies that are born to IBD mothers have different microbiome and higher fecal calprotectin in their stool up to 3 years of life. We don't know what this means, probably just marks some disease susceptibility. So they are offering an anti-inflammatory diet to Crohn's disease women while they are pregnant to see whether that diet has any influence on the microbiome of the baby. Not on whether they will develop IBD, of course, because very likely very few of those babies, or I don't know, 1-2 will develop IBD later in life, and the goal is not to follow them for so long time. But the scope of this project is really to the willingness of people to offer a diet to a child, if that diet may have any benefit, maybe I don't know, maybe a possibility, for example, because it's considered to be a low-risk intervention, while maybe an adult individual, let's say theoretically, that has some biomarkers altered, and that one day in the future we will be able to say that your risk to develop IBD, I don't know, is 75%, may be willing to make some other type of intervention, right? So let me just be clear that so far we have no predictive tool that it's ready for clinical practice, nor any intervention that it's ready for clinical practice. But there are many ongoing studies, many cohorts working on this concept of trying to identify what goes on before IBD is diagnosed, with the goal of eventually one day trying to assess the risk, finding predictors. And then if we can understand the biology before disease onset, we can try to develop a targeted intervention that may be different in infancy or adult life. So the goal of this project is to really know what would people be willing to tolerate as for prediction. You know, would we be willing to make a blood test or a stool test or not? I don't know. Or in terms of intervention.
And do you think then, is the risk greater, less, or equal if the mother has IBD? And this was some of the questions that are coming in.
There were some studies actually showing that there were two studies showing that the risk was greater if the mother had IBD. This was not confirmed in population-based data, so it's not clearly known. So it doesn't look like if the mother or the father has IBD that the risk may be different.
Okay. And another question in from a member is: can prenatal diagnostics during the pregnancy detect it before IBD before delivery? Do you think at any stage? Our members are great.
So there is some data showing that early life exposures may mediate the risk for IBD, but this is mostly from epidemiological data. So it's kind of difficult to know how that data applies to the specific individual, right? So, but the short answer is no. But there is research into this early life, including pregnancy period, trying to assess whether we can find any biomarker or any exposure that can kind of hint us into the risk for developing IBD in the future.
And then another question from a member is there consideration in terms of the psychological support to give to participants in relation to there might be issues in relation to guilt, shame, potentially, that I passed it on to my child? Or
yes, that's a big issue with all prediction and diagnosis in people who don't have symptoms. That's an ethical concern in all the field of medicine. For example, in genetic testing, you have to make sure that the person understands the impact, the psychological impact that a prediction or a test may have. That's why I put in the presentation a balloon saying, "I would rather not know." It's because that's a legitimate concern that like ignorance is it's like sometimes a blessing. So I think that's one of the things we have to explore, especially when we are talking about interventions in children, because they are not themselves going to participate fully in the consent. So the parent is acting like a proxy to the child sometimes. So that's a big issue as well. And it's very important that people feel safe and feel they have the support to deal with information.
What do you see as your biggest challenge when you look at this? I'm sure there's many, many challenges, but when you look at the survey as a whole and your goal, what is the biggest challenge, do you think, both from a patient's perspective and I suppose your own perspective?
My greatest concern is the communication side of it, is to be able to translate into a language that is easy to understand these concepts that sometimes are very hard to wrap your head around. because we have to interplay with lots of odds. What is the odds of me getting the disease? What is the accuracy of the prediction test? What is the safety of the intervention? What is the potential trade-off of the intervention? So my biggest concern is to make this translation between, it's like the movie Lost in Translation, so make this translation between physicians, researchers, and individuals to try to guarantee we are really on the same page, and that we understand what is in what's the problem. And one thing I would like to say, Chiara, is that as Professor Joana Torres said, it's very good that today in the developed world, an IBD patient can have a life expectancy similar to a patient without IBD. That's very good. But what that does is that the prevalence of the disease increases a lot, because from the moment you get diagnosed, you have many years ahead, hopefully, that's great. But new cases keep showing up, and what we see ahead, when the countries that are under development catch up with the incidence, because they are catching up, we will have a huge pool of patients to treat. So we need to search for treatments and for a cure, but we cannot forget to try and make a strategy for prevention, or else it's like a tsunami coming, and we have to have answers for it.
And can I ask, how, when you look at the project, how many groups? Because I think with respect to everybody who's watching, we probably could talk about genetics and cures and causes of IBD for hours ahead. But when you look at the project, how many people or how many groups do you feel that we need to create, I suppose, to get the saturation levels that you're looking for?
We've made available 3 dates in September, and as the interviews and the focus groups go along, we will have the feeling when the subjects are saturated and no other questions or doubts or fears or problems come up. So let's see what you tell us. We need to hear from you. We're on your hand.
And how many patients or how many participants are you ideally looking for?
We need to be careful not to get a very hostile environment, because unfortunately we had anticipated to do this in person, because we think it's more easy to get empathy and get trust and get an environment of spontaneous talking if you are in person. But unfortunately, this pandemic has got he's running our lives, so we had to switch for a virtual setting. So we have set the limit of 6 participants to try and keep this environment so that everyone feels comfortable in speaking and asking for the word, and we think it's a good methodology and has been followed by other researchers before in this field. So I think it's good.
And do you think obviously, because when you were looking at the recruitment, you were saying that English is required. Do you think that's a barrier in the recruitment process?
I think it's an handicap, because we know that one of the most important things is to guarantee that research is valid across countries. And there has been a lot of work in this field trying to guarantee transcultural validity of many tools like questionnaires, quality of life instruments. So we know we need to do better. But for the time being and for launching this project, we will have to stick with English, and then maybe we can, with the global survey, we will have different versions in different languages with translations that are validated, and we can grasp the nuances between cultures. That would be ideal.
Yeah, so for sure the survey the focus group is meant to inform the survey. And we have worked before with Efcca and are working with success, I must say, creating languages in different, creating surveys in different languages. So we would use the same methodology, that we would create different languages so that people can participate even if they were not participating in the focus group. And the goal there would be to reach the maximum of first-degree relatives or parents with IBD. So there we would need the help of Efcca and also the national associations to promote the survey, because it's a little different. It's not directed necessarily to the patients. So we kind of need the patients to kind of alert their FDR, their first-degree relatives. Yeah. So it's a little more challenging because of that.
And I know it's something that Efcca has done some work on before, but do you think down the line, and maybe this is maybe not my generation, the next generation, would it be possible to predict with AI, with artificial intelligence, and interlink it in relation to, I suppose, an intervention or prevention?
So, Chiara, this is what we are currently working. Okay, so there are several cohorts ongoing in Europe and in United States. So I work with several of these investigators, and we have cohorts of people at risk. So first-degree relatives from whom we collect stool, serum, I don't know, all the microbiome, genomic, etc., all the omics. And we have also cohorts who have samples obtained before clinical diagnosis. So, for example, in Portugal, we are collecting baby teeth because we are able to analyze baby teeth in a longitudinal way to assess the early life period. We have a collaboration with the Department of Defense of the United States, where we have serum samples obtained years before diagnosis from those military people. So we are currently working, trying to integrate all these cohorts, and this is a huge challenge, right? Because it requires a lot of work, validation, artificial intelligence, mechanistic studies. So there is a long road ahead. This is something that probably won't happen, I don't know, in the next 2 years. We don't know, but we have published already some of those results. For example, we published last year a tool using proteomics that could predict with 75% accuracy 5 years before diagnosis those individuals that will develop Crohn's disease. Of course, it needs validation, etc. But I would just mention the work in type 1 diabetes that started maybe 20 years ago. And it kind of took time to build the network, to develop all this work. But now they came up with a tool that helps them to predict children who will develop type 1 diabetes with 90% accuracy, which is, I think, really amazing. So, baby steps. We need to keep resilience. But I hope one day, even if we are not able to predict or to prevent, I am sure that this work will help us to understand better the disease processes and potentially to develop better treatments or better therapeutic targets. This is my hope.
So maybe we should say, instead of baby steps, we'll say baby teeth. I love the concept of the baby teeth. And again, some questions are still coming in from different countries. Is there a limit on participants per country?
In the focus group, you mean?
Yes, in the project, yes.
So in the focus, we ask the country. So we would not like to have a focus group with everyone from Portugal, or so we kind of think it's important to have geographic representation. But because we would have different focus groups, we will try to get this representation in the focus groups. And again, like Katarina said, we have 3 dates open for people to register. Eventually, if needed, we will create more dates. But for the survey, everyone is welcome to participate, and the survey is really what will inform the project. I mean, it will be the output of the project.
So, and I have another question. My husband has IBD and I don't. In the view of having a child, I have some concerns, even if I'm not a patient. And can this person participate?
So that's a very good question, actually, because we hesitated on that when we made the project, because I think it's very different to perceive your fears and preferences when you already have a child, than to think about it when you are planning on having a child. I think it's quite different. Of course, it's very important, prospective parents, because there are interventions that can be done before the baby is born, or even after, in the few months after the baby is born, like Joanna has been working on that in Mount Sinai. So we really have to think about prospective parents, but we would, in the focus groups, we would like to, for example, if we had lots of prospective parents, that will give us less clues about the global survey in general, because it's like a niche, it's like a very particular scenario. So for the time being, we would ask first-degree relatives at risk and parents of children at risk. But I think that scenario is very important to explore.
Okay.
I don't know if Joanna or Barbara want to say something about this.
No, I agree with you. I agree.
And I know before we came on live, we were just saying Barbara's in the endoscopic unit. So is the hope down the line, maybe, Barbara, that you won't be sitting there further down the line?
She hopes to be on the beach in the future.
Yes, and not in the endoscopic unit. But I presume with a project like this, and when you look at predictions and interventions, is that there possibly would be that element of it, of the endoscopic and the imagery and stuff like that. Would you agree, Barbara?
I'm sorry, I didn't understand. I'm having a lot of interference. Can you repeat, please?
I suppose, given your setting, is that looking at prevention and intervention will include the diagnostic side of things as well. So, you know, what kind of intervention models can be put in place. You'll still have to have that element of diagnostics.
Yeah, we hopefully, if we, with non-invasive testing, that would be the ideal way to detect the disease without avoiding a colonoscopy. That is an invasive procedure, of course.
And I suppose when you look at it, I suppose I'm just concerned of looking ahead in time. What is the grand, because you did mention that C word, which I think all patients, is the cure. And is the overall aim to look at a cure for Crohn's or IBD?
I think we must do the three things at the same time. So we have to search for better treatments. We have to search for preventive strategies. And as Joanna said, this path can shed light on new avenues we don't know. And hopefully one day, maybe not my generation or the next, but I think the more we know about the disease, the more light we can have on a future cure.
And Chiara, based on what we have learned from type 1 diabetes and rheumatoid arthritis, where they're already conducting disease prevention trials. So not trials to treat the disease, but to prevent. And so far, they haven't been able to find the prevention, but they have been able to show that with some preventions, they could attenuate disease, so make disease a little milder or delay disease. So, you know, it's kind of, I think it's conceptually, we can think that a prevention strategy may modify disease course and bring it into a much milder presentation, or with less severity, or even like you're asking to Barbara, we may be able to get disease earlier, so we may get to earlier diagnosis, and this itself may already completely change prognosis. So there are conceptually all these possibilities, I think, are on our views and on the horizon.
And I suppose it's the first, so I have had IBD for 20 number of years, but it's the first time I've heard medical people talk about prevention. which I think is very brave, and I commend you for that. But maybe you can just a small comment on why working so hard on prevention rather than, I'm sure it's probably it'll put you out of a job if this succeeds.
That's our hope.
To the beach.
But it's funny that you mentioned that, because that's precisely one of the challenges. So it's very difficult to have, the community needs to be like the IBD community. This is an old concept, even if it has been explored for many years in other affiliated immune-mediated diseases. And it's difficult also to find funding, and even to get people engaged, because we are not aiming the patient, right? But the pre-patient.
Yeah.
So, but I think it needs to be done. I think it's important because, like Katerina alluded to, we will have a huge increase in prevalence. It's expected that there will be like 70% increase in prevalence. And so I think this is a way as well to improve patients' lives, because again, we may be able to find, new targets or better understand, because when we are studying disease, we are already studying inflammation that it's already irreversible. So we don't know what's the consequence of inflammation or what's the primary driver for IBD itself. And so if we go back, maybe we can better understand the triggers or, these dysregulated processes, and maybe better intervene in those as well.
Yeah, and I suppose that's an element that probably is missed, is that prevention will help the actual life of those patients, because if you can prevent IBD with a diet, just for example, that allows then I suppose current patients to be able to live with the diet in that sense. Katerina, have you anything about, I suppose, I know you want to go to the beach, but anything about, I suppose, the prevention element of it?
No, I think it's very brave, and I think it's very urgent to talk about this. And I'm very fortunate to work with Joana Torres, because she's always many steps ahead. And so I think this is the way to go, because I don't think we will go out of our jobs, unfortunately, in any time soon. So, but I really hope we can help people live better with this disease and tackle this problem worldwide. So I think it's really urgent to do this.
When you're with the presentation slide, you had the one with the mountains, which was the causes of IBD. How do you link up prevention if we don't fully understand what causes it?
I think that's the process of science. It's like the egg and the chicken. You know more the more you investigate, and the more you investigate, you know more. So it's all good. We have many clues about the disease. It's like a puzzle. But the more we look at it, and if we understand these initial mechanisms that are subclinical, the patient doesn't have symptoms, the patient hasn't had a crisis yet, but something is going on inside many years before. And the more we understand that, the more we understand the disease, the treatment, the cure, the prevention, everything.
It's just so simply like that. I suppose I do have some questions that I'm just going to answer, because I know somebody has said that they've already looked at this survey, but there's no place for adult patients wanting to have children in the future. And I think we've covered that already, in the sense that at this stage, that's not the target audience.
So I think to have a statistic accuracy to do that, we would have to launch a third group, like a third group to try and look at that separately, maybe. But it's a good suggestion, and please pay attention to us, because it can arrive very soon.
So we'll start with the baby teeth, and baby teeth to move on. And then I know somebody else has asked in relation to different languages, and I know that's again something that possibly, hopefully, can come down the line. But in relation at the moment, it will only be starting in English.
No, but it's assumed that the global survey will be available in many languages. That's not something that's up for discussion. It will happen, surely.
Yeah. And then this is a question from one of our members. the study is taking into consideration first level relatives. He has UC and have one son and one daughter with four grandchildren. And I'm worried about that step into the grandchildren. So they're more worried about their grandchildren than their actual children getting IBD.
I think that's
the silence.
Now, that's up to the prediction tool. So the ideal population to validate this is the group at highest risk. The group at highest risk is first-degree relatives. Of course, that second-degree relatives, third-degree relatives can have an increased risk as well. But to start testing the prediction tool and validate it, we need to go to the highest risk population, which is first-degree relatives. When we get a tool with an accuracy above 90%, as Joanna said, other researchers have gotten for type 1 diabetes, we can explore prediction tools for other populations, of course. But for the time being, we must stick to the group with the higher risk.
Okay. I know we're slightly ahead of time, which usually happens with me. And I'm just checking for any more questions, which I don't think we have. I suppose maybe a final word from all of you over on the project and the aspirations for the next few months in relation to it.
Go ahead, Katerina. You can start, Katerina.
So I hope lots of people can watch this live, and then maybe after, I think it will be available to replay for people on their Facebook feed, on their YouTube feed. Hopefully they will use the link and register for our focus groups. And I really hope this has been clarifying for you. And I tried to talk in a way that I think everyone could get on board and understand this. And I really think that it's very important that researchers and physicians work with patient representatives and associations to move research forward. So I thank Efcca and APVI for the opportunity and look forward to working with you hard on the next month.
Barbara,
yeah.
I would like to thank you also for this opportunity, and I hope that our communication was able to answer to your doubts. We made a simple questionnaire like you've seen on the survey, and we really hope to see you soon at the focus group in a online format, of course, but it's how we have to work these days. Thank you.
So Chiara, if I may end, so I just would like to thank Efcca so much, because you're always on board with the craziest ideas. So so thank you so much, because when I approached Efcca initially, I was kind of fearing that this would not be very well, accepted, and they were very enthusiastic. So I really appreciate the opportunity to work with you and with all the national patient associations through Efcca. So I think this is a very important opportunity, because as we are getting along in our research, trying to assess predictors, maybe trying to assess triggers for disease initiation and disease progression, it doesn't make any sense, to find the greatest predictor if then no one will want to, to make it. I don't know, let's say, you need to perform a colonoscopy or a capsule. People will not want this, I guess, right? So it's important. It kind of feeds back into our primary research, because it can help us to refine it. So I think this is the way forward. Like Katerina is saying, it should not be the last step. It should be among the first steps. So I'm very positive that people, the first-degree relatives or the parents of child with IBD who have another unaffected child will want to participate. We are very much looking forward for the focus group. The people always have non-medical people always have a completely different view that we haven't thought about yet. So it will be and we always learn a lot about disease perceptions, etc. So I think it will be very educative for us as well. So just looking forward. I'm very much looking forward.
Okay. On behalf of Efcca, I would like to thank you all for your time this afternoon. I'm sure if we have any more questions that come in as people are watching it, we will pass them on. We will keep the video and we will share the video online, and we'll also share the link as well with all members or anybody watching. So on behalf of Efcca, I'd like to thank you all for your time. And for anybody watching, we look forward to the next patient talks. Thank you very much. Bye-bye.
Thank you. Thank you, Clara. Thank you. Bye. Chiara, thank you for being such an amazing moderator. Amazing.
Oh.
Really, I must say, I'm so surprised. It's like, wow.
No, it was fine. We do have a few technical issues, is that I can't see the questions.